Welcome to VNSG 1332 Neurosensory Problems. This is part 2 of your Neurosensory module. I will be covering 3 disorders: myasthenia gravis, multiple sclerosis, and seizure disorder. Now during this lecture, I have inserted some questions as well as some videos to enhance your learning. Let's get started with myasthenia gravis. Myasthenia gravis means grave muscle disease. It's an autoimmune disorder where the body attacks the neuromuscular receptors that control voluntary muscles. So what are voluntary muscles? They include blinking your eyes, swallowing, chewing, talking. What are involuntary muscles? That includes like digestion of your food, breathing. It's also characterized by excessive weakness and fatigue. And the hallmark of myasthenia gravis is muscle weakness that increases during periods of activity, but it improves during periods of rest. It affects women in their 30s and men over 60. Characteristics commonly seen in these types of patients include, like I talked about, the voluntary muscles, like the eyes. Diplopia, this is double vision. This is usually one of the first signs that you will see. Ptosis, which is eye drooping. With the throat, they could have difficulty chewing. The longer they chew, the more fatigued they become with their muscles. Swallowing, talking. With their face, they'll have a sleepy, mask-like expression, very similar to Sleepy here from Snow White and the Seven Dwarfs. They'll have weakness in the arms and legs, and in severe cases, they'll have diaphragm weakness, which can turn into respiratory weakness. Again, it's generally worse after effort, and it's relieved during rest. Let's talk about some pathophysiology. Here in this picture, we have a normal neuromuscular transmission. You can see the axon, the synapse, the muscle. You also see the acetylcholine and the acetylcholine receptors. So basically, when our brain sends a message, it travels down the spinal cord and through the nerve. When it reaches the muscle, there's a junction that's called the neuromuscular junction. Now you can see that's right around where the synapse says. So the nerve or the axon will release acetylcholine, and the acetylcholine will travel down, find the acetylcholine receptors that are located on the muscle, and then that is kind of like the gatekeeper, and then they will allow acetylcholine to come into the muscle, and then the muscle contracts. So that's what normally happens. Now, how does the muscle know when to stop contracting? Well, our body also releases what's called acetylcholinesterase, and this breaks down acetylcholine and it stops the action of it. So in a sense, acetylcholinesterase is kind of like the teacher who stands in the back of the door, the back of the classroom, and closes the door as the children come in, not allowing any more children to come into the classroom. So what happens with a patient who has myasthenia gravis? Remember, it's an autoimmune disorder. So basically, the body is attacking itself. Well, in this case, the body is attacking the acetylcholine receptors down where you can see on the picture where the muscle is at the acetylcholine receptor sites. There is about an 80% reduction in the number of receptor sites with patients with myasthenia gravis. So if you think about it, you are having the brain send a message that goes down into the nerve, and then it releases acetylcholine. But if acetylcholine doesn't have a receptor, who I call as the gatekeeper, it can't go into the muscle and tell the muscle to contract. Now, there doesn't mean that all of the receptors are damaged, but a lot of them are, and that's why your patient gets very fatigued easily, because it doesn't have enough receptors to see or allow to acetylcholine to come in and make the muscle contract. So it's believed that the role of the thymus has something to do with the antibodies. Now let's go back real quick and remember, what is the thymus? Well, it's a small gland that sits, or an organ I should say, that sits on your sternum. It produces T cells that helps to fight viruses and bacteria, but by puberty it stops producing the lifelong T cells that we will need. So when we'll talk about the treatment for myasthenia gravis, that's why it's very important to remember that you have acetylcholine and you have the receptor sites, and you have to have enough receptor sites to allow the acetylcholine to go in to make the muscle contract. So if we can inhibit the acetylcholinesterase, remember that's like the teacher who stands in the back of the room and shuts the door. If we can inhibit that, then we can allow more acetylcholine to kind of hang out. That way it can go into the receptor sites. So here's another way just to kind of look at it. Okay, if we were in a classroom and there were 30 students in a classroom and there were 5 large doors to get out of, and all of a sudden I yelled fire, all 5 doors would open and the majority of students in 10 seconds would get out of the classroom. With the patient who has myasthenia gravis, we don't have 5 doors anymore. Now we only have 2. So if I yelled fire and we have about 30 students trying to get through just 2 doors now instead of 5 doors in 10 seconds, we're not going to have enough students go through. So we need those 2 doors to stay open longer. That's why we want to inhibit acetylcholinesterase. Let's let the acetylcholine hang out longer to maybe try to find a receptor that is available so that way it can allow the muscle to contract. Here is a easy mnemonic for you to remember. Remember, myasthenia gravis is what? It's weakness. So let's spell out weakness. We have weakness in the face, the muscle, arms, and legs. E is eyelids, like drooping, ptosis, remember that. A is appearance, mask-like, sleepy. K is they keep choking and gagging, especially when they're eating. N is for no energy, so remember it's going to be best to assist them with their activities, especially in the morning, because that's when they'll have more strength. E is extraocular muscle movement. S is for slurred speech, and another S is for shortness of breath. So how do they diagnose somebody who has myasthenia gravis? Well, they will always start with a physical exam and they will do a past medical history. They can do a serum antibody test to see if there's any anti-acetylcholine receptor antibodies. They may do an electromyogram, and this is a type of method where they will record electrical activity of the muscles. They do this by introducing a needle into the muscle. They also can do what's called a tensilon test. Now, this is very interesting. So it's a type of test that they can give a patient, and if they improve, like if they have longer ability to have muscle control, then that usually confirms myasthenia gravis. The tensilon test doesn't last. I can't tell you exactly why, but it's very short term. So the patient will have like big improvement for a short amount of time. Here I'm about to show you a video. It's a video of a dog who actually has myasthenia gravis, and they're going to do a tensilon test on him. Now watch the dog how he walks at the beginning, then they will give him an injection, and then watch how the dog responds. As you can see in the video, the dog really improved pretty fast. But again, this doesn't last very long. As you could see from the video, the medication worked, but it just doesn't last very long. So let's briefly talk about what myasthenia crisis and cholinergic crisis is. With myasthenia crisis, that basically means that the patient has been under-medicated with the anti-cholinerases. Now remember, our goal with the patient who has myasthenia gravis is to inhibit acetylcholinesterase. Let's have the teacher stop closing the doors. Remember that? So the patient, if they're not getting enough medication, they could go into what's called myasthenia crisis. With that, you're going to see severe muscle weakness. They could even go into respiratory failure. They may not have any kind of cough or gag because remember their muscles are really weak. They could have tachycardia and hypertension. Their pupils could be normal or dilated. They also would be at risk for aspiration. Now remember, why is that? That is because the patient is having problems with their muscles, so they aren't able to swallow correctly, which means that they could aspirate. They could also have incontinence of bowel and bladder. So what's the treatment for this? It's to give them more medication because obviously they're under-medicated. With chologenic crisis, this is when the patient has had too much medication, okay? So you're gonna see, again, some very similar symptoms like severe muscle weakness. They could even have respiratory failure because what's happening with here is that the muscle is getting overstimulated. They've got so much of this medication that the muscles are getting overstimulated because it's allowing too much acetylcholine to come in. Well, eventually the muscle's going to get fatigued, okay? So that's why you're going to see some of the same signs and symptoms. With GI, they could have nausea, vomiting, diarrhea, cramping. Now, in this case, they'll have bradycardia and hypotension, and their pupils are going to constrict. They will have increased respiratory secretions, okay? And then they will also you may see some muscle twitching, remember, because it's being overstimulated, and they could have some paralysis. Now, the treatment for chologenic crisis is atropine. So if the patient is exhibiting symptoms that are similar with both, how are they going to know if the patient's in myasthenic crisis or chologenic crisis? Well, they're going to probably give them some Tensilon. So remember the Tensilon test with the dog earlier? So think about this way. If you see these signs of like severe muscle weakness and even respiratory failure, and you give them some Tensilon, do you think that their symptoms are going to improve, or do you think that they're going to get worse? Well, with myasthenic crisis, they're going to actually improve. So if you were going to give them a Tensilon test and you give them this medication and their symptoms get a lot worse, that tells you that they have chologenic crisis. If they find out it's myasthenic crisis, they just need to adjust the medication to where the patient has enough. If they gave them the Tensilon and it was chologenic crisis, they would have to give them atropine to reverse the symptoms. Let's talk about some treatment for myasthenia gravis. Well, the first thing that they're probably going to do is medication. Remember how we want to give them the anti-cholinesterase agents? This will increase the relative concentration of available acetylcholine, so that way if we have more acetylcholine that can kind of just hang around, then they can go find a receptor that is available so they can get into the muscle to make it contract. Here are two different types of medications that you may see: prostaglandin and mistonin. Other medications that you may see the patient be on is corticosteroids, such as prednisone. This helps to reduce the production of the anti-receptor antibodies. They could also do what's called a plasma exchange, where they will remove the patient's plasma, and it's kind of like they kind of clean it out, and then they replace it. What this is believed to do is kind of reduce the circulating antibodies. It has been shown to have some improvement, but it doesn't treat the underlying problem. It just can last anywhere from weeks to months. They can also do what's called a thymectomy. Remember, that's the thymus gland that they believe that produces these antibodies. They will surgically go in and remove the thymus gland, but this may take anywhere even from 2 to 10 years for the patient to even see any benefits from it. There's also some studies about having the thymectomy or having a patient have a thymectomy that 1/3 will actually really see some improvement at the beginning, and about 1/3 will see some improvement years down the road, and another 1/3 may not see any. So of course they're going to want to do the least invasive treatment first. So what are some nursing interventions? Well, you want to make sure that you have their larger meals in the morning, because that's when they're going to have more strength, because they will remember that in the morning they will have more strength, and as the day goes on they become a lot more fatigued. Schedule medications need to be about 30 minutes to an hour prior to eating. And why is this? So that way they have a reduction in aspiration. Have them have small bites. That way they're not having to maybe chew as long and causing more fatigue. We definitely want to try to perform our activities in the morning and give them rest periods. Safety, watch for falls, because remember they're going to be weak with their arms and legs. If they're having visual problems, that's also going to put the patient at risk for falls. So you want to make sure that their room is clutter free. You want to make sure with aspiration precautions you have that head of the bed raised at least 30 degrees, and you want to monitor their respiratory status. So watch their breathing rate, respiration rate. You may have to have some suction at bedside as well. Okay, now it's time for a question. The nurse has explained the use of prostaglandin to a patient with myasthenia gravis. Which comment indicates the need for further teaching? Remember, for the needs for further teaching, we're looking for a wrong answer. A, I should take the medication once a day at bedtime. B, if I take too much or too little medication, I can become weak. C, I will take my medication 30 to 60 minutes before breakfast every day. Or D, I need to take the medication regularly even if I feel strong. The answer is A. I should take the medication once at bedtime. This is a wrong answer. Having the patient take their medication at bedtime is not going to benefit them at all. They need to have their medication on time and in the morning. Next question. Which of the following activity schedule would be most appropriate for the care of a 28-year-old female hospitalized with a diagnosis of myasthenia gravis? A, before meals to stimulate her appetite. B, before bedtime to prevent rest. C, in the morning with frequent rest periods. Or D, all at one time to provide a longer rest period. The answer is C, in the morning with frequent rest periods. Remember, myasthenia gravis is characterized by extreme muscle weakness, which generally worsens after more effort and improves with rest. So we want to make sure that we plan the activities in the morning, but we also give them periods of rest. Next question. The client with myasthenia gravis develops a sudden increase in weakness, accompanied by increase in heart rate from 78 to 100 beats a minute, has difficulty swallowing. Which conclusion can the nurse make from this findings? A, the client is experiencing a mixed crisis. B, the client is experiencing chologenic crisis. C, the client's condition is responding to treatment. Or D, the client is experiencing myasthenia crisis. The answer is D. The client is experiencing myasthenia crisis. Remember, with myasthenia crisis, the patient will exhibit an increased heart rate, which is tachycardia, and hypertension, and that's myasthenia crisis. With both myasthenia crisis and chologenic crisis, they will have muscle weakness. Now let's talk about multiple sclerosis. The term multiple sclerosis means multiple scars or lesions along a protective casing that's called the myelin sheath that surrounds the human nervous system. In multiple sclerosis, it's an autoimmune disorder, so that means the white blood cells are attacking that myelin sheath. And what it happens is it disrupts the flow of impulses that travels from the brain down to the spinal cord to the different sections of the nervous system. This reduces sensation, motor control, and eventually it interrupts most of the voluntary motions like in your arms and your legs. The word demyelinization refers to the destruction of the myelin sheath. The myelin sheath is like a fatty protein material that surrounds and protects the nerve fibers, allowing nerve impulses to travel down. So for example, say I wanted to reach my hand out and I touched a hot stove, just as an example. Then my brain sends that signal down and it says, hey, that's hot because of my nerve endings, and then it tells me to raise up my hand. So that's kind of like an example. So if my brain is going down and trying to say, hey, I need to raise my hand, it's not getting there fast enough because the myelin sheath that protects it has been basically started to be eaten away. Let's look at a picture so that way it makes a little bit more sense. As you can see, you've got the nucleus, here's your nerve, and so it sends down a message and it travels all the way down through the spinal cord and in the brain, and then it goes out here to the nerve endings, which is like, say, to your fingers or your toes or your arms or legs. This myelin sheath protects that nerve, okay? So if you come over here, this is what our myelin sheath, it's really pretty thick, and it protects that nerve so that when it shoots a nerve, it's like it shoots a message that just goes straight across like this. Down here, you can see how the myelin sheath has been damaged, and that is due to white blood cells attacking the myelin sheath. So when they say multiple scars or lesions, in this picture, for example, say this was controlling the arm movement and the white blood cells had been attacking this area, what's going to happen naturally is that the myelin sheath doesn't just get destroyed and is gone forever. It's going to inflame, because remember, that's called the inflammatory response, and it's going to inflame and it's going to try to kind of protect that nerve. And then that'll be okay for right now, and then later on, when those white blood cells come and they attack again, it'll inflame again, but then over time it's going to start developing like a hard plaque, because it thinks that that plaque is going to protect the nerve, when really what it does is it slows the conduction down. So instead of this going shooting very fast down through in the nerve, it's going to go and it'll stop. So then over time, maybe this will start to heal somewhat. And then down here, the white blood cells start attacking here. So I could have lesions here and here. Doesn't mean it has to be all the way down on the nerve ending. Okay, it's time for a question. Which statement concerning the pathophysiology of multiple sclerosis is true? A, degeneration of the axon bodies interferes with signal transmission. B, the autoimmune response causes demyelinization of the nerve fibers. C, damage to the myelin sheath causes an inflammatory response. Or D, poor cellular repair mechanisms support the proliferation of dysfunctional neurons. That's a lot of fancy words. The answer is C. It's damage to the myelin sheath caused by the inflammatory response. The answer B is not right, that even though it is an autoimmune disorder, it's not a response that's causing demyelinization of the nerve fibers. It's demyelinization of the myelin sheath, which can damage the nerve fibers. Here's a video just to kind of reinforce what I just described.
Normally, your immune system helps protect you. It does this by sending in white blood cells and special proteins whenever a foreign substance, like a bacterium or virus, invades your body. Multiple sclerosis is an autoimmune disease, meaning your own immune system is damaging your body. The immune system mistakenly believes the healthy tissue in your brain and spinal cord are foreign invaders. Immune cells are sent from the blood into the central nervous system, where they produce chemicals that cause inflammation. Myelin is a fatty substance that insulates most nerves and helps speed up the communication between your brain and other parts of your body. This inflammation causes the myelin around the nerves to break down, and scar tissue begins to form in its place. This process is called demyelination. The name multiple sclerosis simply refers to the multiple locations where scar tissue or sclerosis builds up in the brain and spinal cord. As the myelin sheath becomes damaged, the electric signals have a harder time getting through or become blocked entirely. As the damage progresses, this leads to problems with your muscle control, vision, speech, sensation, and even your thinking. The symptoms of MS and how severe they are vary from person to person. This depends on how much myelin has been lost and what parts of the central nervous system are affected.
The clinical manifestations Typically, the very first symptoms would include like changes in sensations in the arms, the legs, and the face. They may have complete or partial loss of vision or double vision, weakness again in the arms and legs, or just generalized weakness, unsteadiness when walking, problems with coordination and balance. The onset is slow and insidious, so it doesn't happen all of a sudden. And a lot of times, some people that are having these symptoms, they may not automatically think, oh, this is multiple sclerosis. Sometimes they would contribute it to, oh, I'm just stressed or I'm just tired. So the symptoms could be very vague at the beginning, even for the first couple of months to years before a person would even seek any kind of medical advice. But it's characterized by chronic progression, deterioration in a patient's ability to maybe, like I said, to walk or to see. With MS, depending on how many areas that the myelin has been destroyed and over how long, because like I said, remember in the video, when the white blood cells first go to attack the myelin sheath, it just becomes inflamed, and then it recovers basically. But as it keeps getting attacked over and over again, that's where the body's going to try to put up a defense, and like I talked about earlier, it creates a really hard plaque. That's why sometimes with patients with MS, they'll have these symptoms and then they'll be fine. Like one day the patient can get up and they can't walk to the bathroom, and then a couple of days later or a week later, all of a sudden they can walk. So they just never know if these symptoms are going to stay or for how long. There's lots of different stages, which I'm not going to get into in this lecture, but a patient can have lots of exacerbations, relapses. So the disease itself is kind of tricky at times. For diagnostic tests, of course, they're going to do an MRI, and that allows a lot of visualization of the small plaques. It's usually about 2 separate areas of scar tissue, and that's why it's called sclerosis. Of course, they're going to do a complete history, a neurological test. They may even do a lumbar puncture to check the cerebral spinal fluid to see if there's any antibodies there. They could do what's called an evoked potential studies, such as what they'll do is they'll send lots of electrical signals to the central nervous system, and then they'll assess how the patient responds to that. But an MRI is the more complete diagnostic exam that they will do for a patient to diagnose MS. A little bit more background. Most people are diagnosed between the ages of 20 and 40. Women are 2 to 3 times more likely than men to have MS. It seems that it occurs more often with Caucasians. There is some belief and some studies that they think that the geography or the ethnicity and maybe some other factors could contribute to MS, but again, there's no known cause. The next couple of slides, I'm going to go over talk about the different symptoms that patients with MS could exhibit. Blurred vision, of course, even some pain behind their eyes, muscle weakness. Remember, that's all due to the myelin sheath being destroyed. Altered sense and touch, numbness and tingling. They may experience some pain. The difficulty in the bladder, they either can't control the urge to urinate or they can't completely empty their bladder. With their bowels, they could become constipated or incontinence. They could have some erectile dysfunction or even lack of sex drive. Balance and coordination, I talked about that a little bit earlier, even difficulty with writing, difficulty speaking, cognitive issues, loss of memory, can't concentrate, depression. This is due to the changes in the brain resulting from the MS. They can have lots of spasms, stiffness, tightness, usually in the arms and the legs can be painful, fatigue, and extreme tiredness. I like this little cartoon on here. It says online medical advice. It says, according to this website, my symptoms show that I'm dead. Just a little humor for you. Here's a small video clip just to show you a little bit more.
Of MS, people often experience muscle weakness, tingling or numbness, loss of balance, blurred or double vision, and or eye pain. As the disease progresses, other symptoms may appear, such as muscle stiffness, heat sensitivity, fatigue, pain, difficulty thinking clearly, and sexual problems. The symptoms of multiple sclerosis generally appear between the ages of 20 and 40. It's important to know that MS can begin so mildly that a person doesn't even notice any symptoms until the disease has progressed. Also, The symptoms vary from person to person and can change over time.
I'd like to show you this commercial that's about MS. It's going to show you how MS can affect lots of different people. The music is going to be in Dutch, just to let you know. So you can see how in the lady in the bathtub, when she couldn't get out, she could move because she was weak, even the man who was walking, and then the woman at the end who was having visual disturbances. For therapeutic measures, there are multiple types of medications that a patient with MS can be put on, and this is, again, not to cure the disease, but to help to control the symptoms. So remember at the beginning when I said that the white blood cells would go and attack the myelin sheath, and the myelin sheath would then become very inflamed. So one thing that when it is inflamed, it doesn't really constrict on the nerve, but it does slow down the production of the transmission of the nerves to be able to travel across to send signals from the brain to the rest of the body. So by giving them Solumedrol IV, remember it's an anti-inflammatory, so it's going to decrease that inflammation. And that way the nerves can have the transmission going a lot faster. Prednisone is also one that they may be on for more long term. For the bladder, like I talked about earlier, oxybutynin is what they would give a patient if they could not, if they were having problems with urgency to go. Bethanechol is given for patients who have problems with urinary retention. Now, there is a couple of modification courses for MS, such as beta interferons. Now, what beta interferons do is they work by altering or suppressing the activity of the immune system. So they kind of mimic a protein that's found in the body. So they basically go out and they block those certain white blood cells that are attacking the myelin sheath. They can also stop other white blood cells from releasing the T cells that also would go and attack the myelin sheath and cause the inflammatory response and the destruction of the myelin sheath itself. Now, with this, with beta interferons, the Avonox is an injection that's given to the patient. You want to make sure that you're teaching the patient to rotate the sites. They need to make sure that they wear sunscreen, protective clothing, and inform the patient that if they develop any kind of flu-like symptoms, that they need to make sure that they let their healthcare provider know. Now, glatiramer acetate is also another type that would help modify the course. What glatiramer acetate does, it increases the good white blood cells to go stop the bad white blood cells, like the T cells, from attacking the myelin sheath. Other things would be like for the symptoms, a patient could be on Valium that helps with this symptoms, as well as the baclofen for spasms that can be given either PO or as a pump. Nursing interventions, we definitely don't want the patient to have any excessive heat. Like, don't give them a heating pad, keep the room cool, because that seems to bring on a lot of the symptoms. Decrease stress. Infection can also bring on the symptoms. You want to promote the physical mobility. They may need to have some kind of assisted device, prevent any kind of injury. Again, have their walker handy or anything like that, their wheelchair. Exercise is really important because this helps to increase their energy. Swimming is one of the best exercises for that patient because it doesn't tire them out as much. And also exercise really helps to decrease depression. We talked earlier about assisted devices, but don't forget that shower chairs, make sure the room is clutter-free, have everything where they need visually if they can, because if their vision is interrupted, you need to make sure that you're telling them where everything is located. For the bowel and the bladder, For bowel, you want to make sure that you're increasing their fiber. They may need to have some stool softeners and skincare. For the bladder, put them on a voiding schedule. Maybe offer to give them the bedpan, or offer every couple hours to have them go to the restroom. If they're incontinent, you definitely want to make sure that you're providing good skincare. The patients may even have to self-catheterize themselves, especially if they aren't able to release any of the urine. And make sure they keep their fluid intake up. During exacerbation, the patient may be bedbound, so make sure that you're focusing on preventing complications of immobilities such as any kind of pressure sores, UTIs, respiratory problems. Managing their speech and swallowing difficulties, maybe asking them yes or no. If they're able to write instead, that can also help. Promoting home and community-based care. See where the patient's at when the patient is being discharged, to see if they're going to need any other kind of assistance at home. So just remember that just because they're exhibiting symptoms, because they're in flare-up, if you want to call it, or exacerbation, it doesn't mean they're always going to be like that. But the problem is we never know how long they will. So talk to your patients who have MS. If they've had it for years, they'll tell you exactly what, especially with medications, not all medications work for them, but they will tell you what works for them in the past and what hasn't worked. They will also let you know that, hey, I know that whenever I start to have this flare-up, it usually lasts about, a week, or maybe it lasts for just a couple of days. So make sure you communicate and talk to your patient. Okay, it's time for a question. Which of the following statements is correct about MS and life expectancy? A, the greater a patient's disability at a given point in time, the shorter her life expectancy. The stress and inactivity associated with MS lead to a higher heart attack rate in MS patients. Nowadays, few MS patients die of complications. D, few patients live with MS for more than 10 years. Or E, no one has died from MS complications. The answer is C, few MS patients die of complications. With all the advanced technology, research out there, MS patients are living a lot longer life than they used to. Okay, we're at the end of our multiple sclerosis part, and I would like for you to watch a video. It is with an actress named Selma Blair. Some of you may recognize her. It's just a really great video. It's about 8 minutes long, but I think that you'll enjoy this.
Selma Blair, the interview. Here's Robin Roberts.
How are you doing?
I am doing very well. I am very happy to see you being able to, just put out what being in the middle of an aggressive form of multiple sclerosis is like.
Selma Blair has a message for the world. Multiple sclerosis may have affected her voice, but not the power of her words.
When I first got MS, I had no idea what it was or how it would affect me. And so my speech, as you'll notice, is I have spasmodic dysphonia right now. It is interesting to put it out there, to be here to say this is what my particular case looks like right now. And it could be very different in a year for the better.
The actress speaking for the first time about the disease she's been battling for years.
It's called a snowflake disease because it's different, like a fingerprint for everyone. Wow. Not one size fits all.
Wow. On Sunday, Selma made an emotional return to the red carpet.
Take your time.
For the first time since going public with her diagnosis 4 months ago, attending the Vanity Fair Oscar party with the support of her customized cane. A moment of triumph. Her tears of happiness earning cheers from the press line. The actress became a household name in movies like Legally Blonde, The Sweetest Thing, and of course,
Are you for real?
Cruel Intentions.
You want to learn or not?
Sarah Michelle Gellar, one of my dearest, called this morning and said I'm really helping to change people's lives. I can't bend my left leg well.
For years, her illness was a mystery. The 46-year-old suffering troubling symptoms. She says doctors didn't take her seriously, so she developed her own coping mechanisms.
I was drinking. I was in pain. I wasn't always drinking, but there were times when I couldn't take it. And I was really struggling with how am I going to get by in life and not taken seriously by doctors. Single mother, you're exhausted, financial burden, blah, 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 hormonal, premenopausal, postmenopausal. I mean, no one said, maybe you should get an MRI. Maybe we should just check it out.
You would ask for that, and they would just rebut
and
them.
they just would say, no, we should probably. And I even got to the point where I said, I need to go to work and I have to stay awake. I dropped my son off at school a mile away, and before I got home, I'd have to pull over and take a nap. And I was ashamed, and I was doing the best I could, and I was a great mother, but it was killing me.
MS is a chronic, often unpredictable disease of the central nervous system, which is made up of the brain, spinal cord, and optic nerves. It can cause problems with vision, balance, and muscle control. Before she was diagnosed, Selma sought out the help of fellow actor Michael J. Fox, who has lived with Parkinson's disease for nearly 30 years.
I reached out to him before I was diagnosed, and I DM'd him. And I said, I don't know who to tell, but I'm dropping things. I'm doing strange things. I have a tremor. My pinky won't stop moving. My leg, I can't feel. It's bouncing. And I said, I'm sorry if this is inappropriate. I didn't know who to turn to. And I don't know him. It was because he was a celebrity that was an actor that came out, that's still working, that talks about it. He got in touch with me, and we began a conversation. And my MS hits in spots that make it very Parkinsonian. Plus, I was like, I have Michael J. Fox's email now. Like, I'm pretty cool. Like, I'm cooler than I thought. Wouldn't it be funny if I fell in for real? Not really.
After years of suffering, it was a fall in front of a doctor that eventually led to her diagnosis last August. When you were first diagnosed, what initially went through your mind?
I cried. I had tears. They weren't tears of panic. They were tears of knowing I now had to give in to a body that had loss of control. And there was some relief in that, because ever since my son was born, I was in an MS flare-up and didn't know. And I was giving it everything to seem normal. I wasn't totally worried, but I did have about 10 minutes of crying. And then immediately got on the phone with my manager because I had to be in Atlanta the next day to finish a movie.
The basic cause of MS is still unknown, but experts say it's at least 2 to 3 times more common in women than men. How difficult was it to share it with your son?
Not at all. But he had already seen that I was falling and doing things, and I was always laughing, and he'd imitate me. I'd be like, that's fine, but don't do that out of the house. People think you're a jerk. And so I did have to tell him after the MRI, I said, I have something called multiple sclerosis. And he almost cried and said, will it kill you? And I said, no. I mean, we never know what kills us, Arthur. But this is not the doctor telling me I'm dying. And he was like, oh, okay. And that was it.
For Selma, her diagnosis has also given her a new mission.
If I can help anyone or help anyone be more empathetic to someone that might seem like me or a lot worse, God forbid, then, that's the least I can do right now.
She's hoping to create a line of adaptive clothing for people with disabilities.
Well, I think people need the confidence to not feel invisible once you have an illness.
Beautiful.
That is kind of where my mindset is,
And she's still an actress, people.
I'm still an actress.
Still an actress.
Mama still gotta bring home the bacon. I'm a single mom.
And Selma is still working, part of an upcoming sci-fi drama series on Netflix called Another Life.
What propelled me to really come forward was authentic gratitude for all the people that were holding my secret at Netflix and on the movie after. When it's a huge thing for people with disabilities, minor or major, that you can still find a way, hopefully if you believe and persist, to still get to work.
Her message of perseverance coming through at that emotional Vanity Fair red carpet on Sunday, moving even the press. Getty photographer Mike Coppola quickly snapped this powerful image, sharing his story on Instagram saying, quote, She turned around, put her left hand in the air, and paused for a second as she was determined to take control of her body. I took my favorite shot of the night right then and captured one of the most vulnerable human moments I have been a part of. What are doctors telling you? What's your prognosis?
The doctor I saw, he said within a year, I could have, at the time, he said, 90% of my abilities back. So this is to say, let's meet again next year and see if I'm better, if I'm not. And I can still have a conversation that's good enough. I was a little scared of talking. And even my neurologist said, no, this will bring a lot of awareness because no one has the energy to talk when they're in a flare-up. But I do, because I love a camera.
Oh, baby.
So the video that you just watched was very inspirational. This is the end of the multiple sclerosis part. The last part of this module is over seizures. Seizure disorders are episodes of abnormal electrical signals that are being fired from the brain. They can have a brief unconscious period or altered consciousness. So think of this. The brain has neurons, which is responsible for transmitting information. There are two different types of neurons specifically for seizures. You have the excitatory. When these neurons are stimulated, they cause a response by stimulating a neurotransmitter called glutamate. So this basically is just the firing off, okay? For inhibitory, they inhibit the response or they stop the transmitters from being released, and this is releasing GABA. So one more way just to think about it is there are two types of neurons for seizures. Excitatory is when they stimulate out, okay? So they send a signal out from the brain, and in order for that signal to be stopped, it is the inhibitory, which that releases GABA. A healthy brain has a balance of both. So I need you to understand the difference between the excitatory and the inhibitory, because when the inhibitory is damaged, and we'll talk about that in a little bit, the excitatory takes over, causing seizures. This is going to be very important to remember when we discuss medications, specifically barbiturates, that inhibit the excitatory neurons from being stimulated. So what causes seizures? Well, seizures can happen to anyone. It could be due to illness such as high fever, central nervous system infection, hypoglycemia, alcohol and drug withdrawal, hypoxia, brain tumors, head trauma, gastrointestinal disease, poisoning. Seizures are usually identified from their physical and behavioral signs and symptoms. With infants and toddlers, this is usually caused by high fevers, which can really be very traumatic for parents. Epilepsy is a little bit different. Seizures are usually just like a one-time deal. Like I said, it could be caused from like a high fever or injury. Epilepsy is a recurring seizures caused by more of a chronic underlying condition, like a severe brain injury, congenital, a severe stroke, idiopathic, meaning they're not really sure where it's coming from, maybe a long-lasting illness. Let's talk about the different stages of seizures. You have the prodromal, which is prior to a seizure. You have the oral, which also is prior. You have the ictical, which is during the seizure. And you have the post-ictical, which is after. For prodromal, these are symptoms that usually happen before the seizure, even days. They can include depression, anger, anxiety, GI or GU issues. For oral, this may not happen with all seizures. This is usually with the focal or tonic-clonic seizures. This can happen seconds to minutes prior to a seizure. So it's very important as a nurse, if you are taking care of a patient who's had seizures, ask them if they've ever had any orals before, because that will usually let the patient notify the staff that they're about to have a seizure. This can include altered vision or hearing, a deja vu moment, a weird smell, or a taste. Ictical is during a seizure. It can last anywhere from 1 to 3 minutes. The patient may have some apneic breathing at times. If this lasts longer than 5 minutes and or another seizure begins back to back, this is called a status epilepticus. We will discuss that a little bit later. For post-ictal, this is after the seizure. So this is when the brain is trying to recover. Your patient is probably going to exhibit confusion. They're probably going to sleep. They'll be very tired. They may have a headache. They may even have some injury depending on what type of seizure, like head trauma or biting their tongue or their cheek. So when you think about the post-ictal, this is like after the brain has ran like a marathon. It is exhausted. There are two different types of seizures that we're going to talk about: partial and generalized. With partial, this is just in one specific area of the brain. You can have a simple or a complex. Let's talk about simple. A simple is whenever the patient is aware of what's going on during the seizure. It's usually short, like less than 2 minutes. The patient or the person will remain conscious, but they may experience some unusual feelings or sensations. They usually have an aura. They may experience a sudden or unexplainable feelings such as joy or anger or sadness or nausea. They may even have a type of smell, taste, hear, or feeling that they have. With complex, they're not aware of what is happening. They may have some like lip smacking, rubbing of the hands. They have a change or a loss of consciousness. They will also display what is called automatism, and that is repetitive behavior. Like I said, the blinking, the lip smacking, twitches, sometimes maybe even walking like in a circle. Now let's talk about generalized seizures. This affects the whole brain, so it's all over. It's not just in one area like in the focal. This can include tonic-clonic, also known as grand mal, absent, which is petechial mal, or atonic, which are called drop attacks. With generalized seizures, they are a result, like I said, of the abnormal neuroactivity on all sides of the brain. These are the most common. They tend to have an aura. These seizures may have a loss of consciousness, which pushes the patient at risk for falls. So they'll firstly go into, with the tonic-clonic, they'll go into a tonic phase, which is where the muscle starts to stiff. They may groan, cry, bite their tongue, have some apneic breathing. Then they'll go into the clonic, which is the recurrent jerking. This is where they may lose some bowel and bladder. They usually last, the tonic-clonics, about 1 to 3 minutes. Again, if it's longer than 5 minutes, this is an emergency. With an absent seizure, this is usually noticed in children and rarely in adolescents. And the hallmark sign is staring and daydreaming. This is what I call whenever I'm giving a lecture. And all of you probably right now are having what's called an absent seizure. So when the students are staring back at me and they're just blinking, I just say, oh, look, you're having an absent seizure, even though you're not. It can go unnoticed because, like I said, the child may look like they are like having, they're kind of daydreaming. It's very short, like in seconds. And afterwards, they recover immediately, but they don't really remember anything. I kind of think of it like when you've been driving in the car and you just kind of drove and all of a sudden you don't even realize how you've gone 20 miles and how did you get there. With an atonic seizure, this is caused by a loss of normal muscle tone. The patient can fall down, so you have to watch for injury to the head, or if they're sitting, their head may just like hit a desk or wherever they are. For children, this is when they may, if they have a history of having atonic seizures, they may have to wear a helmet just to protect their head. They usually remain conscious, and again, this one only lasts usually for seconds, like 15 seconds. Okay, I'm going to show you a video of a person who's having a tonic-clonic seizure. It's about a minute long, so just kind of watch the patient, how he goes into the tonic and then the clonic, and then I really want you to watch how the patient is at the end of the seizure, and he's having this at home. You'll have to excuse the barking. So remember, he's in the ictical phase. It's during the seizure. He has some apneic breathing. And now he's getting towards the end. And he is asleep. And you can hear him snoring. So do you see how his brain is so exhausted? Some diagnostic tests are going to, the most common is going to be an EEG, which is an electroencephalogram. With this, you have to just teach your patient that it's painless. They usually don't allow any kind of caffeine or any kind of stimulants prior to this. They will even hold the seizure medications. You want to make sure that the hair is clean and dry because they're going to put little electrodes on their head. The patient, depending on what type of seizure they're testing for, they may have the patient be sleep deprived. They also may be monitoring for the patient if they needed to use like any kind of lights or sensories to kind of stimulate a seizure, because they're wanting to see how the brain is going to react when the patient's having a seizure. So just remember, they are in a controlled environment. They could do a CT scan and MRI. They're definitely going to get a history and physical of the patient and any family histories. Here's a little cartoon for you. On the left, the man is telling the other guy, it says, "He keeps staring at me. Do you think he's having some kind of seizure?" And the guy on the right says, "Managing negotiations, chapter 3, maintaining eye contact while reinforcing image of strength and warmth." Just a little humor for you. Here is a picture of an EEG being done. On the left, you can see a normal, and on the right, this is somebody who's having a generalized seizure. So you can see all of that brain activity going. Let's talk about some therapeutic measures as a nurse. The first thing that you want to do is make sure to assess if your patient's even at risk for having a seizure. You may have to have some seizure precautions, such as having oxygen and suction available, IV access. Some facilities require the bed rails to be padded just to prevent any kind of injury. You want to make sure the patient has no kind of restrictive clothing on. You may want to ask your patient if they've had any auras prior to a seizure, and because this will help the nurse to know when a seizure may be happening or about to happen. Also ask your patient, how long does the seizure happen? Ask them the last time that they took their dose of medication. You also need to look if there's any kind of therapeutic range for medications, for example, like Dilantin, which we will talk a little bit later. During the seizure, you definitely want to prevent your patient from having any kind of injury, so you may have to ease them to the floor. You're going to put them to a side-lying position, so that way they don't have to worry if they were to start to vomit, and you don't want their tongue to roll back either. It's really important as a nurse that you time the seizure. The minute that the patient is having a seizure, you go ahead and look at your watch and time it there. There may be instances where you walk into the room and the patient's already in having a seizure, but that's okay. Just make sure you look and you notice the time. If the seizure, again, lasts longer than 5 minutes, or they have another seizure that goes back to back, or if the patient stops breathing after a seizure, or there's been any kind of injury, you need to get medical attention immediately. You want to make sure that you're assessing the airway. You don't put anything in their mouth, though. Loosen their clothing if you need to. You will never restrain a patient or hold them down. You just want to try to keep them protected. Emotional support is very important, especially for a patient who's never had a seizure. They're going to wake up and be very confused, and you want to let them know that they're safe. After a seizure, the patient is probably going to fall asleep, or they're going to be very exhausted, just like in the video a while ago. Don't attempt to give them anything to eat or drink. Just orientate them as they are starting to wake up. And you might want to get some vital signs and do a good neuro assessment. For anticonvulsants, barbiturates, which are also called phenobarbital, are used. These are used to treat tonic-clonic or focal and status epilepticus. Remember at the beginning of the lecture when I said there are two different types of neurons, the excitatory and the inhibitory. With phenobarbital, this works as an inhibitory. So if the inhibitory neuron has been damaged, that's why the phenobarbital for an anticonvulsant is used, so it can stop the excitement of the neurotransmitters. Some side effects that you'll need to watch for if a patient is on a barbiturates is drowsiness, respiratory depression, hypotensive. You want to make sure that you're looking at their drug levels if they're drawing that one, and they usually will be anywhere from 15 to 40 micrograms per milliliter. Another type is a phenytonin, which is also known as Dilantin. This is used for a tonic-clonic or focal again. The big thing with this is you want to watch for their gums, and because they'll get what's called gingivital hyperplasia, and there's a picture right there for you. It's a very bad side effect. Watch for bone marrow suppression, a rash. You don't want to give any kind of milk or antacids because this will interfere with absorption. Benzodiazepines are also used for absent or tonic-clonic and focal. Examples is diazepam or lorazepam. This is the most common one that they will also use for status epilepticus because it's very fast acting. Side effects of the benzos, again, is drowsiness. Watch for impaired liver function. And the antidote is called the flumezazole. It's Flumazennil. Valproics or valproic acid. These are used for all different types of seizures. You also want to monitor their liver, their white blood cells, platelets, and any kind of GI issues. There are other types of therapeutic measures such as surgery. That's whenever they're going to remove the area of the brain causing seizures. This is not very common, but they may need to do this. They'll also do what's called a vagal nerve stimulator. There's a picture right there. This is very similar to when a person has like a built-in defibrillator. So when the excitatory neurons are going off, if medications maybe aren't working, they may have to do a vagal nerve stimulator. So what this does is it says, hey, excitatory neurons, y'all need to stop. And that way it kind of acts as a inhibitory. A ketogenic diet is also used for pediatrics when medications don't work. It's a high-fat, low-carb. It's very important as a nurse that you want to teach your patient what are things that can trigger a seizure. So a nice acronym is called STOP seizures. So for STOP, it could be stress, trauma, overexertion, some periods or menstrual cycles, and pregnancy. For seizures, it could be sleep loss, electrolyte and metabolic imbalance like hypoglycemia or dehydration, illness, visualization disturbances like some sounds and smells. They can be under-medicated, recreational drugs, and the use of alcohol. These are all different things that can trigger seizures. Let's briefly talk about a status epilepticus. So this is considered an emergency situation. This is when a seizure is lasting longer than 5 minutes and the patient has stopped breathing, or if they were to have a seizure and it ended and then they had an immediate seizure. Why this is so important to get medical treatment immediately is because the patient can go without breathing, and that's going to cause brain damage and even some swelling that could be irreversible. So if you walk into a patient's room or you're in a patient's room and they're having a seizure, again, remembering to time it and watch your patient to see how they are responding. You can call for assistance but it's not something that you would necessarily have to call an actual code for. If the patient were to have a seizure lasting longer than 5 minutes and they had completely stopped breathing, and or like I said, they have a back-to-back seizure because they're not getting enough oxygen to the brain, that is when a code will need to be called. Management of status epilepticus, we talked about earlier. This is where they're going to give the benzos, like the lorazepam or the Valium, and that is going to be given IV because it just kicks in quick. You want to maintain airway, get oxygenation to the brain. The brain must be given some rest because this will not allow the patient to breathe and can cause some irreversible brain damage. Once the seizure has been basically kind of taken care of, that's where they're going to start looking at, okay, what caused this to happen? Were they under-medicated? Maybe they need to switch the medications on the phenobarbital or the phenytonins, like the Dilantin. But if a patient is having a status epilepticus, they are going to need to have Valium or Ativan given IV. Okay, it's time for a question. The client is experiencing status epilepticus. Which of the following drugs should the nurse have ready to administer? A. Tegretol, B. Atropine, C. Lorazepam, sorry, they should say C, and D. Propranolol. The answer should be Lorazepam. This is administered IV because this is an emergency situation. The nurse is caring for a client who begins to experience a seizure activity while in bed. Which of the following actions by the nurse would be contraindicated? So you're looking for a wrong answer. Would it be A, restraining the client's limbs to protect them, B, removing the pillow and raising padded side rails, C, maintaining a patent airway, D, positioning the patient to a side-lying position if possible with the head flexed, or E, loosening restrictive clothing? The answer is A. You would not restrain the patient in any way, even just to try to protect them. You might want to move some stuff out of the way, but you cannot restrain a patient because then you can cause more harm. The nurse has given medication instructions to a client receiving phenytonin, Dilantin. The nurse determines that the client has adequate understanding if the client verbalizes, so you're looking for a correct answer. A, I can adjust my medication dose depending on the side effects I have. B, I need to take care of my teeth during thoroughly brushing and flossing. C, I can have a small glass of wine at bedtime. D, I should take my medication if I am to have my phenytonin blood drawn in the morning. The answer is B. I need to take care of my teeth with thorough brushing and flossing. Remember, with Dilantin, one of the biggest side effects is gingivital hyperplasia. That is the end of this lecture. If you have any questions regarding any of the topics that were covered, such as myasthenia gravis, muscular sclerosis, or seizure disorder, please email me and let me know.